So today I'm going to be talking about tic disorders. There are 4 different diagnoses for tic disorders that we see in the DSM-5. There's Tourette's disorder, persistent chronic motor or vocal tic disorder, provisional tic disorder, and other specified and unspecified tic disorders. Today I'm going to be focusing on 2 and 3, however I will touch upon 1 just a little bit. So what is a tic? A tic is a sudden, rapid, non-rhythmic motor movement or vocalization. And they're generally involuntary, but they can be voluntarily suppressed. So say somebody's embarrassed by their tic, or they don't want to do it in public, they can voluntarily suppress it, but it is very difficult since these are generally involuntary. There's 2 different types. There's complex tics and simple tics. Complex tics are something that we see when somebody yells out a curse word, any socially unacceptable word they will yell out. They will repeat the last heard word or phrase from somebody else. They'll repeat their own sounds or words, they'll make obscene or sexual gestures, or they might imitate somebody else's movements. Whereas with a simple tic, we see that they experience eye blinking or throat clearing. There's plenty of other ones, but these are the 2 that are most common across patient populations. Tics too tend to wax and wane in severity. We might see that earlier on in the day. Somebody's tics might not be as severe as later on in the day when they might experience something very stressful, or they might get severe anxiety. That's when the tics tend to present themselves more. We also see that some individuals may go periods of weeks to months without experiencing any tics at all. Tics usually are brought on with the average age onset of between 4 and 6 years old, so very early on in somebody's life, and we typically see this mostly with younger children. And just a quick note is if you've seen transient tic disorder, that was basically the old name for provisional tic disorder. Provisional tic disorder is used now for that. It's the same exact thing, and in the DSM-5 it's used as that as well, so that's what I'm going to be using. So some diagnostic criteria for persistent chronic motor or vocal tic disorder. We need to see a single or multiple motor or vocal tic that have been present during the illness, but you cannot have both a motor and vocal tic. That is Tourette's, that you have both of those, and provisional, you can have both, or you can have either one as well. Tics may wax and wane in frequency, but they have to be present for more than 1 year since the first tic onset, and the onset has to be before the age of 18. The disturbance also cannot be attributable to the physiological effects of a substance or any other medical condition, such as Huntington's disease, which we will talk about a little later. And they also cannot have met the criteria for Tourette's disorder at all during their year of experiencing these tics. Provisional tic disorder, it's a single or multiple motor and or vocal tic, so you can have one or you can have both, either or. And the tics have to be present for less than a year. So this is the step basically before the chronic tics. The onset is also before 18, and there can't be a disturbance attributable to the physiological effects of a substance or the medical condition. And you also cannot have met criteria for Tourette's disorder or persistent motor or vocal tic disorder. So course and prevalence. Tics are common in childhood, as we saw that the average onset age is between 4 and 6. We also see that males are more commonly affected than females. And we also see that the frequency of identified cases is actually lower among African Americans and Hispanic Americans, and this is largely related to differences in the access to care that they have. The peak severity of tics is between the ages of 10 and 12, with a decline in adolescence, and we also see that a small percentage of individuals will have persistently severe worsening symptoms in adulthood, but it's a very small percentage, as we see that tics do decline starting in adolescence, so that causes for the small percentage of adults to continue to have tics. As children get older, that's when their tics start to associate with the premonitory urge and that feeling of tension, and that they need to reduce that tension, so that's why they perform the tic. So as they get older, this is when they really feel it, that they really need to let out the tic to let out the tension. Whereas some younger children might just do it because they have to, like it just happens. It's very, very involuntary. Children with tic disorders are more likely to experience ADHD, OCD, and separation anxiety disorder. I think tic disorder sounds a lot like OCD, So I can see that definitely, except with obsessive compulsive disorder, the individual is obsessing over something like washing their hands or turning the light switch on and off because, they might think that they're dirty, or, somebody might die that is close to them if they don't do that action. Whereas tic disorder, it's an involuntary action. They can't help it. And it's not because they think something bad is going to happen. It's because they feel this tension in them and they need to reduce the tension. So that's the main difference between them. But I'll talk a little bit more about that later. And adults and teenagers are actually more likely to experience major depressive disorder, substance use disorder, or bipolar disorder as compared to ADHD, OCD, and separation anxiety, along with the tics. Prognosis. So their temperamental effects are that tics are worsened by anxiety, excitement, and exhaustion. They can also be worsened by stressful, exciting events, which makes sense because somebody can get very tense from being stressed out. My brother actually had a tic disorder when he was younger, and it was due to stress because he was being bullied at school. So he acted out, or his tics came out a lot after being bullied. So that made his tics very severe. Calm or focused activities actually make tics fewer. It releases the tension in the individual's body. Environmental impacts, if they observe a gesture or sound in another person, it may result in the individual themselves. It may, it may make them stressed out to the point where they have to act out the tic, or the action in the other person might actually relate to the tic that they do and might make them do that. And this can be a problem when they interact with authoritative figures, because if they do a complex tic, such as yelling an obscene word, that might not be appropriate in the situation they are in, especially with law enforcement or teachers. Genetic and physiological impacts. The genetic environmental factors influence tic symptom expression and severity. There are rare genetic variants in families with tic disorders that have been identified, and it tends that altered paternal age, lower birth weight, and maternal smoking are associated with worse tic severity. So we see with cultural considerations that there does not appear to be a varying clinical characteristics. However, it may impact how tic disorders are perceived and managed in the family or community. So, as well as influencing patterns of help seeking and choice of treatment. So the real differences in culture is how one seeks help. It's not different in how different cultures show the disorder. It's how the different cultures choose to treat the disorder, as well as how they view the disorder and how willing they are to go seek help for it. So a little background information on tic disorders. Tourette's syndrome was actually named after Gilles de la Tourette. This happened after he was a student in France and his mentor turned his attention to paroxysmal movement disorders, which are neurological illnesses characterized by sudden outbursts of emotion and or action. So there it is. There we see the tics that he saw. So Tourette's syndrome was named after him. However, he was probably one of the first people to diagnose and figure out tic disorders in general. Etiology is not particularly known, but it tends to be familial. Twin studies support genetic factors. Monozygotic twins are more likely, whereas dizygotic twins are likely, but not nearly as likely. It's also hypothesized that ADHD is comorbid with the disorder, which has been proven in cases. We do find a lot of children that do have ADHD along with tic disorder, whereas the hypothesis that suggests an abnormality of dopamine in the brain of somebody with a tic disorder, there has been no evidence that has been uncovered for that, so it's not really used or believed in the field. So it's just a hypothesis right now. Some tics are just brought on by stress. That's how it is. It does not, there is the possibility for no genetic cause at all, just simply stress. Assessment. Tics are usually easy to identify. However, sometimes the simple motor tics can be difficult to distinguish because they might just be a normal movement or due to some other kind of disease or disorder. Neurologic examination shows no focal signs at all. This is why a clinician really needs to rely on their observations and on other things as well, because as it says on the bottom, they should not rely solely on observations, since tics do tend to vary throughout the day. So when somebody gets more stressed, tics get worse. When they're more relaxed, tics aren't as worse. So they can't rely solely on their observations, even though observations do help. So there are some rating scales, including videotaping protocols, which we actually did for my brother. We recorded him because, you know, when we went to go see the clinician, his tics weren't as severe as when at home after school they were severe. So we videotaped it to show the clinician how bad they would get. So that's either a direct examination and or historical examination, historical records. There are other types of scales. I'm just going to name them off: Hopkins Motor and Vocal Tic Scales, Yale Global Tic Severity Scale, and the TS Clinical Global Impression Scale. Some differential diagnosis. There are a couple things that can be mistaken for tic disorder sometimes. Chorea in adults. This is when you cannot maintain a sustained position, and it's a rapid and random unpredictable actions that can affect the whole entire body. Harlequin's tongue, attempt to protrude the tongue, tongue often pops in and out. Huntington disease, involuntary movements, dementia, and behavioral changes. So with these, we all see that part of the disease is that they are doing these actions. It's involuntary because the disease is making them do it. However, it's the sole reason of the disease itself. It's not due to any stress or anything like that, whereas a tic disorder would. Some other disorders we see are obsessive-compulsive, substance-induced disorders, and myoclonus, which is twitches, jerks, or seizures caused by sudden muscle contractions, which we can tell right away just by reading the definition that that is not related to tic disorder, because those are just sudden muscle contractions just due to the muscles contracting, whereas tic disorder, it's an involuntary reaction due to stress and tension buildup. So tic disorders, they really require movements or vocalizations that are sudden and involuntary. And once again, they can be brought on by stress to relieve, and are done to relieve the stress. So these are the key things we have to look for when diagnosing to differentiate this disorder from others. Treatments include CBT, medication, treatment of comorbidities, and comprehensive behavioral intervention for tics, which is something new. It may help some older children control or reduce the number of severity in tics, so it's mainly used to reduce the severity, and it's a habit reversal therapy that's used. There's also relaxation training and contingency management, which are rewards for not performing the tics. The medications include clonidine, which is common, antipsychotics, only if their tics are comorbid with some other type of disorder that they would need an antipsychotic for. That's only if it's needed. Flufenazine, and overall, the lowest dose required to make tics tolerable is what is needed. The doses do taper as the tics wane, and the medication is strictly symptomatic. The medication will not cure tics. It's basically just to make the symptoms tolerable. So it's really just used based upon the severity of symptoms. What I have next is a vignette that I came up with. I have it in the handout, so if you want to read that, read that and read along with this. I'm just going to point out some key things about the vignette that will explain why Derek, who is an 8-year-old Caucasian boy from New York, who is experiencing tics from stress because he's being bullied at school, why he has provisional tic disorder. So his tics have only been happening for about 3 months, and he's throwing his head backwards. That's his tic. So he doesn't have ADHD, and otherwise he's considered to be in good general health. It's just this tic that he keeps doing that his parents have noticed. So he would be diagnosed with provisional tic disorder because his tics have only been happening for about 3 months. So he can't have chronic tic disorder or Tourette's. And in this case, he only has one tic, which would classify him as provisional tic disorder because it can either be one type of tic or both. But the key thing here is that it's only been happening for 3 months. And lastly, here are some references. Thank you.